Case number 7 is a 27-year-old with a new diagnosis of AML and fever. He's not on any medications and he does not have any complaints. If you look at his labs, his white count is 10,200 with 5 segs, 60 blasts, 20 lymphs, 12 monos, 3 EOs, and his chest X is clear. So he looks okay. He does not have any distress, so he's not started on any antibiotics. So the number 7 rule of use of antibiotics is that you have to respect patients' neutrophil count. If you look at this patient, he only has 5% segs, so his ANC is close to 500, so he's neutropenic. Remember, the definition of neutropenia is ANC less than 1,000. Neutropenia increases your risk of infection. The mechanism is translocation of bacteria from the mucous membranes and from the GI tract, and it can cause sepsis and death. So that is why anybody with neutropenia, anybody with neutropenic fever needs to be on antibiotics. Empiric, cefepime, and usually vancomycin is added if they have a Metaport or PIC line, according to the guidelines, IDSA guidelines. Now, if they're sick, you probably want to add additional coverage with aminoglycosides. Case number 8 is a 35-year-old HIV who has a CD4 count of 335. His CD4 count has been ranging between 335 and 461. And he comes in with shortness of breath and cough and fevers. So he has not been taking his Bactrim for the past few months. Chest X shows bilateral infiltrate. So PCP pneumonia is suspected and he started on IV Bactrim. So the next rule of antibiotic use is you have to honor patient's CD4 count. Remember, PCP pneumonia is very rare with CD4 count of less than 200. This patient's CD4 count has been ranging between 335 and 461, way above 200. So PCP pneumonia is very, very unlikely in this patient. So honor the patient's CD4 count. CD4 count is basically the measure of his immune system. If the CD4 count is less than 200, if the CD4 count is low in the patient, you have to treat him as an immunocompromised patient. If the CD4 count is normal, your differential diagnosis should be similar as it would be in any other patient. Remember, the most common opportunistic infection in HIV patient is recurrent community-acquired pneumonia. Case number 9, patient hospitalized for about a week with fevers and clinical deterioration. So he started on Zosyn, but 2 days later, a pulmonary embolism is diagnosed, and his blood cultures grow MSSA, methane septum staph aureus, and he's still febrile. So the lesson to learn here is always reevaluate your empiric antibiotic therapy. Empiric means good guess. So if the patient has a pulmonary embolism, are we really treating an infection here? If the patient is growing MSSA, then antibiotics should be de-escalated. If the patient still has fevers, in that scenario, Zosyn is not helping his condition, and then you need to look for an alternative explanation of his fever. So pulmonary embolism can cause a fever, or non-infectious etiologies can cause a fever. So always reevaluate your empiric antibiotic therapy after 24-48 hours. Go back and look at your cultures, make your differential diagnosis, and start your diagnostic workup. Antibiotics should be reevaluated after 48-72 hours after they're started. Case 10 is a diabetic with chronic foot ulcer with surrounding erythema and edema of the leg. He started on ertapenem. He's showing improvement. His plain X-ray is negative for osteomyelitis. He has a bone scan done, which says that it cannot rule out osteomyelitis. So he's prescribed 3 weeks of IV ertapenem. So So the rule number 10 is do not give half the correct treatment just because your diagnosis is half correct. So you have to ask yourself what you're treating. Are you treating a skin and soft tissue infection, or are you treating osteomyelitis? If you're treating skin and soft tissue infection, the duration of antibiotics should not be more than 10 to 14 days. If you're treating osteomyelitis, 3 weeks of IV antibiotic is not going to be enough. You need longer than that. You need 6 to 8 weeks of IV antibiotic therapy. So always make a commitment to the diagnosis and ask yourself what will be the consequences if I am wrong. Have a conversation with the patient and decide whether you're going to treat for osteomyelitis or skin soft tissue infection. And then you can be open with the patient and tell them that, if the diagnosis, if it turns out to be the other way, then the treatment plan will be changed. So in summary, please go through these again. I want to point out these 10 rules of antibiotic use. Number 1, antibiotics are not antipyretics. There are non-infectious etiologies of fevers. Please consider those. Number 2 is do not treat colonization. Differentiate between colonization and infection. The next one is coagulative staph is usually a contaminant, especially single blood culture. Other contaminants in blood cultures are Corynebacterium, Bacillus, and diphtherids. Next one is always try to use most narrow spectrum antibiotic. Number 5 is assess for and avoid cross-reaction in true penicillin allergy. Number 6 is if an antibody has 100% bioavailability, you should use PO route. And some of these include quinolones, metronidazole, linezolid, fluconazole, voriconazole. Always respect patients' neutropenic. Always in a neutropenic patient with a fever, always put them on antibiotics. And if you have an HIV patient, pay attention to his CD4 count. Number 9 is reevaluate empiric antibiotic therapy. Stop, narrow, or commit to a course. The last one is make sure the duration of antibiotic therapy is appropriate for your treatment diagnosis. Hope that helps. Thanks.